Type 2 diabetes does not arrive suddenly after 50. It has been building quietly inside the body for a decade or more, through a chain of biological events that most people were never warned about, never tested for, and never given the language to recognize until the diagnosis was already sitting on the table in front of them. Most people who are diagnosed with type 2 diabetes after 50 are genuinely shocked. They did not feel sick. They were not eating dramatically worse than anyone else they knew. They were not living what they would describe as an unhealthy life. And yet, their pancreas was failing, their cells had stopped responding to insulin, and their blood sugar had been climbing for years in a direction that nobody caught until it had already caused damage. The reason most people are shocked is that nobody explained to them how type 2 diabetes actually develops, the real biological sequence that begins years before diagnosis, the specific causes that drive it most aggressively, and why the body after 50 is uniquely and significantly more vulnerable to that sequence than the body at 35. Today that changes, because understanding the real cause is the only foundation from which meaningful prevention or reversal becomes possible. Type 2 diabetes after 50 is not primarily a disease of eating too much sugar. It is a disease of a metabolic system that has been overwhelmed by a specific set of biological forces over many years. Think about what the years between 40 and 55 actually looked like for most people. Careers at their most demanding, children grown but still needing, parents aging and needing care, sleep getting shorter, movement getting less frequent, stress staying high, meals getting faster and less considered. And through all of it, the body adapting quietly, compensating silently, managing, until one day it could not manage anymore. The diagnosis did not come from one bad decision. It came from the accumulated weight of a decade of biological pressure that the body absorbed for as long as it could. Understanding that sequence is not about assigning blame. It is about seeing clearly what actually happened, so that what happens next can be different. Here is what we are going to cover today. Type 2 diabetes is not a single condition with a single cause. It is the end result of a specific sequence of biological failures, beginning with insulin resistance, progressing through pancreatic beta cell stress and decline, driven by specific and identifiable forces that become dramatically more powerful after 50. We are going to look at the most dangerous of those forces, what each one is, exactly how it drives the metabolic system toward diabetes, and why the body at this stage of life is particularly vulnerable to each one. Clear language, real mechanisms, practical understanding. By the end of this video, you will understand the real biological sequence behind type 2 diabetes after 50 in a way that most people, including many who have already been diagnosed, were never given. That understanding is what makes meaningful change possible, because you cannot interrupt a process you do not understand. This video is for educational purposes only, is not medical advice, and is not a substitute for guidance from your own healthcare provider. If you have concerns about your blood sugar or diabetes risk, please speak with your doctor. What insulin resistance actually is and why it starts the whole chain. Before we look at the specific causes, we need to clearly understand the central mechanism that all of them feed into: insulin resistance. Because without understanding it, none of what follows makes complete sense. Insulin is a hormone produced by the beta cells of the pancreas. Its primary job is to act as a key, unlocking the doors of cells throughout the body so that glucose from the bloodstream can enter and be used for energy. When you eat a meal and blood sugar rises, the pancreas releases insulin. Insulin travels to cells throughout the body. It binds to insulin receptors on those cell surfaces, and the cells open their glucose channels. Blood sugar enters the cells. Blood sugar in the bloodstream drops back to normal. The system works elegantly and continuously, thousands of times across a lifetime. Insulin resistance is what happens when the cells stop responding to insulin's signal effectively. The key is still being produced, the lock is still there, but the mechanism inside the lock has become stiff and unresponsive. The insulin arrives, binds to its receptor, and the cell does not open its glucose channel the way it should. Glucose stays in the bloodstream longer than it should. The pancreas, sensing that blood sugar is not dropping, responds by producing more insulin, working harder to compensate for the reduced cellular response. Blood sugar is eventually managed, but only through an insulin output that is far higher than it should need to be. This compensatory hyperinsulinemia, the state of chronically elevated insulin that the pancreas produces to overcome resistance, is the phase that runs silently for years and sometimes decades before diabetes is diagnosed. Blood sugar tests during this phase often appear normal or only mildly elevated because the pancreas is compensating effectively. But the compensation is costing the beta cells enormously. They are working at a pace they were not designed to sustain indefinitely. And as the years pass and insulin resistance deepens, the beta cells begin to fail, first producing slightly less insulin than resistance demands, then producing significantly less, and eventually losing the capacity to produce enough insulin to manage blood sugar at all. At the point where beta cell output can no longer compensate for the degree of insulin resistance present, blood sugar rises beyond the diagnostic threshold. Type 2 diabetes is diagnosed, and the process that led there began not months, but years, often 10 to 15 years before that moment. Most dangerous cause number 1: visceral fat and its direct attack on insulin signaling. The most dangerous single driver of type 2 diabetes after 50, the one with the most direct, most potent, and most comprehensively documented relationship to insulin resistance, is visceral fat. Not body fat in general, not the fat that sits beneath the skin on the arms, legs, and hips. Specifically, the fat that accumulates deep inside the abdominal cavity, surrounding the liver, the pancreas, the intestines, and the other organs of the digestive system. This fat is biologically unlike any other fat in the body, and understanding why is the key to understanding why type 2 diabetes becomes so dramatically more common and more aggressive after 50. Visceral fat is not metabolically inert storage tissue. It is an active endocrine organ, producing and releasing a continuous stream of hormones, inflammatory molecules, and metabolic signals into the bloodstream through the portal vein, which drains directly into the liver. Among the most significant of these signals are free fatty acids, fat molecules released from visceral adipose tissue into the portal circulation at rates that are far higher than the liver can process efficiently. These free fatty acids arrive at the liver in concentrations that directly disrupt the liver's insulin signaling machinery, causing the liver to become insulin resistant, to keep producing glucose even when insulin is telling it to stop, and to manufacture and store more fat within its own cells. This is how visceral fat produces fatty liver, and how fatty liver and insulin resistance feed each other in a cycle that deepens with every passing year of visceral fat accumulation. Visceral fat also produces inflammatory cytokines, particularly tumor necrosis factor alpha and interleukin-6, that circulate systemically and directly impair insulin receptor function in muscle, fat, and liver cells throughout the body. Inflammation and insulin resistance are not just associated with each other. Inflammation is a direct biochemical cause of insulin receptor dysfunction. The inflammatory molecules produced by visceral fat physically interfere with the intracellular signaling cascade that allows insulin to open glucose channels in cells. And because visceral fat produces these molecules continuously, around the clock, the insulin resistance they generate is not a response to any single meal or lifestyle event. It is a constant, baseline disruption of insulin signaling that runs without pause. After 50, visceral fat accumulation accelerates significantly for reasons that are specific to this stage of life. In men, the gradual decline in testosterone that begins in the late 40s promotes a shift in body composition. Muscle mass decreases and visceral fat increases, even without any change in diet or activity level. In women, the dramatic drop in estrogen at menopause removes the hormonal protection that previously directed fat storage toward the hips and thighs rather than the abdomen, and visceral fat accumulation accelerates rapidly in the years following menopause. In both sexes, the age-related decline in growth hormone, which promotes fat metabolism, and the increase in cortisol sensitivity, which promotes visceral fat storage, compound these hormonal shifts. Physical inactivity, which becomes more common after 50, removes the muscle contractions that would otherwise drive glucose uptake independent of insulin and metabolize the free fatty acids that visceral fat is releasing. The waist circumference measurement, simple, free, and available without any medical equipment, is the most accessible proxy for visceral fat burden. Research consistently shows that waist circumference above 35 inches in women and 40 inches in men is associated with significantly elevated visceral fat and significantly elevated metabolic risk. This measurement, combined with a fasting blood glucose and an HbA1c, gives a person and their doctor a very clear picture of where visceral fat-driven insulin resistance currently stands and how urgently intervention is needed. Research has documented that even a 5 to 7% reduction in body weight, achieved primarily through visceral fat loss via dietary improvement and aerobic activity, produces measurable reductions in insulin resistance, liver fat, and inflammatory cytokine production within 8 to 12 weeks. Visceral fat responds faster to lifestyle intervention than almost any other fat depot in the body. Most dangerous cause number 2, chronic inflammation as an independent driver of beta cell destruction. The second most dangerous cause of type 2 diabetes after 50 is one that operates through a mechanism entirely separate from visceral fat, though the two are deeply interconnected, and that is chronic systemic inflammation acting directly on the beta cells of the pancreas to destroy their function and reduce their number. Beta cells are the insulin-producing cells of the pancreatic islets, specialized clusters of cells embedded within the pancreatic tissue. They are extraordinarily sensitive to inflammatory signaling. In acute inflammation, this sensitivity serves a purpose. Inflammation suppresses insulin secretion temporarily as part of the stress response, redirecting glucose toward immune activity. But in chronic inflammation, the kind that runs persistently for years, driven by visceral fat, poor diet, sedentary habits, and chronic stress, the continuous exposure of beta cells to inflammatory cytokines produces something far more damaging than temporary suppression. It produces progressive beta cell dysfunction, cellular stress, and ultimately, beta cell death. The inflammatory molecule interleukin-1 beta is one of the most specifically and most directly documented drivers of beta cell damage in type 2 diabetes. It impairs the beta cell's ability to secrete insulin in response to glucose, triggers oxidative stress within the beta cell that damages its mitochondria, and activates cell death pathways that reduce the total number of functioning beta cells over time. Research has shown that the islets of people with type 2 diabetes contain significantly elevated concentrations of interleukin-1 beta, produced locally by immune cells that have infiltrated the islet tissue in response to the metabolic stress and fat deposition that chronic inflammation promotes. This local islet inflammation compounds the systemic inflammatory damage to create a pancreatic environment that is progressively less capable of producing the insulin the body needs. After 50, the inflammatory burden on the body increases for several converging reasons. The immune system undergoes a process called immunosenescence, age-related changes in immune function that include a shift toward a more chronically activated, pro-inflammatory baseline state. This age-related increase in baseline inflammation, sometimes called inflammaging in the research literature, creates a higher starting point of inflammatory stress on the beta cells before any dietary or lifestyle factor is even considered. A diet high in ultra-processed foods, refined carbohydrates, and omega-6 fatty acids from processed seed oils adds significant dietary inflammatory burden on top of this age-related baseline. Poor sleep, particularly the fragmented, non-restorative sleep so common after 50, drives inflammatory markers upward through disruption of the regulatory processes that normally keep nighttime inflammation in check. And chronic psychological stress maintains cortisol at levels that promote both visceral fat accumulation and direct inflammatory pathway activation. The dietary pattern most consistently associated with reduced inflammatory burden and with reduced beta cell stress and improved insulin sensitivity in research is one centered on whole, minimally processed foods, with an emphasis on vegetables, legumes, whole grains, fish, olive oil, and nuts. This pattern reduces the dietary sources of inflammatory signaling, provides antioxidants that protect beta cells from oxidative damage, and delivers the fiber that supports a healthy gut microbiome, which itself has a profound and increasingly documented influence on systemic inflammation and insulin sensitivity. Some people are wondering, if inflammation is destroying my beta cells, can I get them back? Research shows that while severely damaged beta cells cannot be fully restored, reducing inflammatory burden in the earlier stages of beta cell stress allows remaining beta cells to recover significant function, which is why early intervention produces dramatically better outcomes than waiting for full diagnosis. The window for meaningful beta cell recovery is real, but it is not unlimited. Most dangerous cause number 3, muscle loss and the disappearing glucose sink. The third cause is one of the most underappreciated in the entire diabetes conversation. And yet the research on its contribution to insulin resistance and blood sugar dysregulation after 50 is among the clearest and most consistent in metabolic medicine. It is the progressive loss of skeletal muscle mass that begins in the 40s and accelerates through each subsequent decade, a process called sarcopenia, and its profound effect on the body's primary glucose disposal system. Skeletal muscle is the largest glucose-consuming organ in the body by volume. At rest, muscle accounts for a significant proportion of the body's glucose uptake. During physical activity, that proportion rises dramatically. Contracting muscle can take up glucose through an insulin-independent mechanism, directly transporting glucose into the muscle cell through channels that activate with movement rather than waiting for insulin's signal. This insulin-independent glucose uptake during exercise is one of the most powerful blood sugar-lowering mechanisms available, and it works regardless of how insulin-resistant the cell is, because it bypasses the broken insulin signaling pathway entirely. When muscle mass declines, as it does progressively after 50 in people who are not actively maintaining it through resistance training and adequate protein intake, the total glucose sink available to the body shrinks. There is simply less muscle tissue available to absorb the glucose that arrives in the bloodstream after meals. The liver and the remaining muscle must handle a larger share of glucose disposal. If the liver is already insulin resistant from visceral fat burden, and if the remaining muscle is also insulin resistant from chronic inflammation and inactivity, the glucose has nowhere efficient to go. Blood sugar rises higher after meals. It stays elevated longer. The pancreas produces more insulin to compensate, and the beta cells accelerate their decline under the strain of chronically elevated demand. Research tracking adults over 50 for periods of 5 to 10 years has shown a strong and consistent association between lower muscle mass and higher rates of type 2 diabetes development, independent of body weight, body fat percentage, and other metabolic risk factors. The muscle mass itself, through its role as a glucose sink and through the metabolic signaling that contracting muscle generates, is a direct protective factor against insulin resistance. Its loss removes that protection progressively and silently, with each passing year of inadequate physical activity and inadequate protein intake. Resistance training, the kind that challenges muscles to work against load, whether through weights, resistance bands, bodyweight exercises, or any other progressive resistance, is the most direct and most effective intervention for preserving and rebuilding muscle mass after 50. Research has shown that even adults in their 60s and 70s who begin a consistent resistance training program show significant increases in muscle mass, significant improvements in insulin sensitivity, and significant reductions in fasting blood sugar over 12 to 16 weeks of training. The muscle responds to the stimulus at any age. The glucose sink can be rebuilt, but it requires the specific stimulus of resistance training. Aerobic exercise alone, while valuable for many reasons, does not produce the same degree of muscle mass preservation or rebuilding. Before today, did you know that muscle loss after 50 could be directly accelerating your risk of type 2 diabetes, completely independently of what you eat or how much you weigh? Drop a yes or no in the comments. This connection is one of the most important and most overlooked in metabolic health. Most dangerous cause number 4. Chronic sleep deprivation and its direct effect on glucose metabolism. The fourth cause is one that most people have never seen listed in any diabetes prevention material. And yet, the research connecting poor sleep to insulin resistance and type 2 diabetes is now extensive, consistent, and mechanistically clear. Chronic sleep deprivation, getting less than 6 to 7 hours of quality sleep per night on a regular basis, directly impairs glucose metabolism through multiple pathways simultaneously, in ways that are measurable within days of sleep restriction beginning. The most immediate mechanism involves the hormonal changes that sleep deprivation produces. Even 1 week of restricted sleep, reduced to 5 to 6 hours per night in controlled research settings, produces measurable increases in cortisol, increases in the hunger hormone ghrelin, decreases in the satiety hormone leptin, and direct impairment of insulin sensitivity in muscle and liver cells. Cortisol, at the chronically elevated levels that sleep deprivation maintains, promotes glucose production by the liver, raising fasting blood sugar, and directly impairs insulin receptor signaling in peripheral tissues. The combination of increased hepatic glucose output and reduced peripheral insulin sensitivity produces a blood sugar environment that mirrors early-stage insulin resistance, even in previously metabolically healthy subjects. Sleep deprivation also impairs the first-phase insulin response, the rapid initial burst of insulin secretion that the pancreas produces within the first few minutes of blood sugar rising after a meal. This first-phase response is critical for catching the blood sugar rise early and preventing it from climbing too high. Research has shown that after sleep restriction, this first-phase response is blunted. The pancreas is slower and less robust in its initial reaction to rising glucose, and postprandial blood sugar spikes are higher and more prolonged as a result. This is exactly the pattern of beta cell dysfunction that characterizes early-stage type 2 diabetes. After 50, sleep quality deteriorates for multiple reasons already discussed. Changes in sleep architecture, sleep apnea, hormonal shifts, medication effects, and conditioned arousal patterns. The result is that a very large proportion of adults over 50 are chronically sleep deprived or chronically sleep disrupted in ways that are directly worsening their metabolic health every night, independent of any dietary or activity consideration. Research has shown that people with sleep apnea have significantly higher rates of insulin resistance and type 2 diabetes than age-matched people without sleep apnea, and that treating sleep apnea with CPAP therapy produces measurable improvements in insulin sensitivity, sometimes comparable to the effect of a first-line diabetes medication, without any change in diet or exercise. The practical implication is direct and important. For adults over 50 with elevated blood sugar or insulin resistance, sleep is not a peripheral lifestyle consideration. It is a metabolic intervention. Treating sleep apnea, improving sleep hygiene, addressing the behavioral and medical causes of nighttime waking, and consistently achieving 7 to 8 hours of quality sleep are not simply quality of life improvements. They are direct inputs into the glucose metabolism system, inputs that reduce cortisol, restore first-phase insulin response, improve peripheral insulin sensitivity, and reduce the inflammatory burden on beta cells every single night they are implemented. Most dangerous cause number 5, chronic psychological stress and the cortisol-glucose cycle. The fifth cause brings together several threads that have appeared throughout this video. Because chronic psychological stress does not produce a single isolated metabolic effect. It produces a cascade of interconnected effects that touch visceral fat accumulation, inflammation, sleep disruption, and insulin signaling simultaneously, making it one of the most pervasive and most underaddressed contributors to type 2 diabetes after 50. The cortisol-glucose connection is the most direct. Cortisol is a glucocorticoid hormone, a hormone that, by its very nature, raises blood glucose. It does this because its evolutionary purpose is to provide emergency fuel during acute threat situations, mobilizing glucose from the liver into the bloodstream to power the fight or flight response. In acute stress situations, this is appropriate and temporary. But in chronic stress situations where cortisol remains persistently elevated, the liver keeps producing and releasing glucose into the bloodstream continuously, independent of meals and independent of the body's actual energy needs. Fasting blood sugar rises. the pancreas produces more insulin to manage it. Insulin resistance deepens. Beta cell demand increases. Cortisol simultaneously promotes visceral fat storage, directly stimulating the accumulation of deep abdominal fat through its action on cortisol receptors that are particularly dense in visceral adipose tissue. It promotes muscle breakdown, reducing the glucose sink at exactly the same time it is flooding the bloodstream with glucose. It suppresses immune regulatory function in ways that increase the pro-inflammatory cytokine environment, damaging to beta cells. It disrupts sleep architecture, reducing the restorative sleep that metabolic health depends on. And it drives appetite toward high-calorie, high-sugar, high-fat foods through its interaction with the reward circuitry of the brain, producing the stress eating pattern that delivers precisely the dietary inputs that worsen insulin resistance most aggressively. After 50, the life circumstances that generate chronic psychological stress are often at their most complex and most unrelenting. Financial concerns about retirement, health challenges arriving with increasing frequency, grief and loss becoming more common experiences, relationship transitions, and the psychological weight of watching the body change in ways that feel outside of control. These are real stressors, not imagined ones, and their metabolic consequences are equally real. Research tracking adults over 50 for periods of 5 or more years has documented a clear dose-dependent relationship between chronic perceived stress and the development of type 2 diabetes, with higher stress levels predicting faster metabolic deterioration even after controlling for diet, physical activity, and body weight. The stress reduction interventions with the most consistent evidence for metabolic benefit are those that produce lasting reductions in sympathetic nervous system activation and cortisol output, not those that simply feel relaxing in the moment. Regular aerobic exercise reduces sympathetic tone and cortisol reactivity over time through adaptations in the hypothalamic pituitary adrenal axis. Mindfulness-based stress reduction programs have documented effects on cortisol levels, inflammatory markers, and in some studies, measurable improvements in fasting blood sugar and HbA1c in adults with prediabetes. Consistent, adequate sleep reduces the baseline cortisol elevation that sleep deprivation maintains. And meaningful social connection, genuine relationships that provide emotional support and reduce the subjective experience of stress, directly reduces inflammatory markers and improves the hormonal environment in which glucose metabolism operates. Research has shown that type 2 diabetes, even after formal diagnosis, can be put into remission through intensive lifestyle intervention, with the strongest evidence coming from programs that address visceral fat, muscle mass, sleep, inflammation, and stress simultaneously, rather than focusing on any single factor. The metabolic system is damaged by a combination of forces, and it responds to a combination of corrections. Before we close, I want to hear from you. Out of these 5 causes, visceral fat, chronic inflammation, muscle loss, sleep deprivation, and chronic stress, which one hit closest to home today? Which one made you see your own health picture differently? Drop it in the comments below. And if someone you care about has been diagnosed with prediabetes or type 2 diabetes and has only been given dietary advice and a medication, please share this video with them. Understanding the full picture of what is actually driving the condition is what opens the door to addressing it fully. That is worth sharing. Thank you for being here today. Type 2 diabetes after 50 is not inevitable. It is not simply the price of aging. It is the result of a specific set of biological forces that, when understood clearly and addressed specifically, can be slowed, stopped, and in many cases, reversed. What you learned today is the foundation of that understanding. Take it with you. Take good care of yourself. Stay curious, stay moving, and I will see you in the next one.